I'm Richard White. I'm the Chief of Surgical Oncology at the Levine Cancer Institute and Atrium Health here in Charlotte, North Carolina. I have the great privilege of interviewing Dr. Steve Edge. Dr. Edge, would you like to introduce yourself?
I'm Stephen Edge. I'm a surgeon and Vice President for System Quality and Outcome at the Roswell Park Comprehensive Cancer Center in Buffalo, New York, and Professor of Surgery at the State University of New York at Buffalo.
I should also note that Dr. Edge was the chair of the Commission on Cancer from 2008 to 2012. So thank you, Dr. Edge, for taking the time to do this.
Well, thank you for having me.
And as you know, these reflections will be part of the 100th anniversary campaign of the Commission on Cancer. You have played a major role in the Commission on Cancer over the last many decades. Could you reflect a little bit on your time as chair of the Commission on Cancer and what you thought we were able to accomplish?
Sure. Well, this is really nice that you're doing this. It's amazing, but it has been 100 years of the Commission. People in other oncology specialties forget that the surgical community addressed quality of care and comprehensive care long before other people thought that it was even something to think about. So we have a lot to be proud of as surgeons in the multidisciplinary field of cancer care as it's grown. I came into the Commission in sort of a time of transition and change. The Commission had largely been focused on setting structural standards for hospitals, maturing the cancer registry. I came in the late 1990s. Actually, I was the representative of the American Society of Clinical Oncology for 3 terms before I became chair of the QIC. And I think that represents the maturation of the organization, that it went from FASCO felt they put a surgeon into the and now it's a leading position at ASCO. I think it shows the maturation of the Commission on Cancer. But it was a time of transition. David Winchester had worked with the American Cancer Society to form the National Cancer Database, so 8 or 10 years before late 1980s, before I joined the Commission. And the change was that the Commission was growing into being a true quality evaluator and quality measurer and quality feedback organization that would really use direct measurement of data that we collected to help providers and institutions assess and improve the quality of care that they provided. And towards that end, while I was representing ASCO, the committee structure was redefined at the Commission. And one of the committees that was formed was the Quality Integration Committee, which of course now is, the prime committee at the Commission. And I was the inaugural chair of the QIC back in 2000, I don't know, 4 or 5 or whatever it was. And that grew out of work that I did with Andrew Stewart at the behest of Lamar McGinnis, one of the great figures of both the College of Surgeons and the Commission on Cancer from the 1970s, 80s, and 90s. A remarkable man from Atlanta. And he, of course, had close connections with the American Cancer Society. And Mr. Stewart and I developed a program with the Tenet healthcare system to assess quality. And what I said was, rather than simply look retrospectively at cancer care, we should measure cancer care in real time in a way that we can impact on the patients who are actually being measured. And we established a number of quality measures and a mechanism by which we could collect that data and feed it back. And that program became our QRS system, and those measures became the first measures that were implemented in the CP3R program, what we now know as the CP3R program, though they've changed the name again. But so those measures are still in place. I remember writing those measures at my computer here at Roswell Park back in the early 2000s of endocrine therapy with breast cancer and radiation after breast conserving surgery and chemotherapy and colon cancer. We took things that were obvious that should be done. And not only do we improve the quality of care in those measures, but we also helped identify pitfalls and problems in collecting data so that programs became much better at collecting the data as they were forced to actually collect these measures. So I think my first accomplishment with the Commission on Cancer, honestly, was working with Andrew and of course, Dr. Winchester and Connie Bureau to establish the quality measurement program and put that in place at what became CPCR and RQRS. They then asked me David called me and asked me if I would be willing to serve as chair. And of course, it took me about a microsecond to accept that offer. So I had big shoes to fill, though. I followed Rick Green as chair of the commission, and Rick is, of course, legendary of the College of Surgeons and the Commission on Cancer for his lifelong commitment to the programs, and there's very big shoes to fill. And he's been a great mentor to me over the years. I think during my term, we really matured the quality measurement program and grew it into what it could become today. We provided the foundation for what it's become today. Quality measures across multiple diseases, quality measures that are being collected real time. The real-time cancer measurement program we started in RQRS is now being extended across all cancer sites under the leadership of Heidi Nelson and others. We're seeing that program really mature to provide real-time data collection and therefore real-time help to our patients. I mean, that's the goal here, isn't it? The goal is to improve quality for patients, not to just look retrospectively. The goal of our quality measurement program isn't just to ding doctors. The goal is to help the doctor, to help them provide better care. So I think that's one of the big things that we did in that time. The other thing that happened under my tenure was we developed what we call patient-centered standards. There was a revision of the standards during the time that I was chair, and we pushed having patient-centered standards included. And the three that were included were the survivorship care plan, which, it's had its problems over the years, and it's morphed in the current standards into a survivorship program rather than just a measurement of how many people you provided a survivorship care plan. That's a good change. The distress monitoring tool and genetics. So real patient-centered programs. And I haven't told this to too many people, but honestly, I think my proudest accomplishment as the chair of the Commission on Cancer was suggesting and then implementing through a committee structure that we had to bring patient advocacy groups directly into the commission as full members, not as advisors, not as a subcommittee, but as full members of the Commission on Cancer. And that was in 2010 or 2011. 2010. And those were the Cancer Support Community, the Livestrong Foundation, and the National Coalition for Cancer Survivorships. I think that was an important addition to the commission to add the patient voice, in addition, of course, to the voice of the American Cancer Society, but to add the patient voice to the deliberations of the Commission on Cancer. Something that we've learned over the last couple of decades is really important. So if I've done all this work with quality and the commission did all that work, but I think one of the proudest achievements I had was to really push that through and get those advocacy groups to be a member. And I think they've proven their worth to the commission over the last decade. I was followed by Dan McKellar, who brought a little more community view to the program. Andrew and I recruited Larry Schulman to join the commission and become chair of the QIC. And of course, Larry went on to be the stellar chair of the commission. Honestly, being on the commission was one of the proudest accomplishments in times of my life. And I think we've made great contributions, all the team, David Winchester, of course, Connie, Andrew, Asa, the whole crew. It's really quite a remarkable group that works in.
Thank you so much for sharing that. You've been involved in cancer care your entire career. Where do you think the Commission on Cancer sits in the pantheon of cancer care organizations in the United States and around the world? And what contributions do you think the Commission has made to the broader care of the American cancer patient?
Well, it harks back to the 100th anniversary, right? And what we said very early on, that the surgical community has been involved in assessing and improving cancer care for over 100 years before the field of medical oncology even existed. Now we work in a multidisciplinary environment with our wonderful colleagues across all these disciplines and with our patient colleagues. But the commission still remains the only organization that reviews, assists, and accredits cancer care across the entire community. And here I work at an NCI-designated comprehensive cancer center, and I'm very proud to work here. But the majority of patients that are cared for in America are cared for in smaller settings and potentially less specialized settings in our community. And what the commission does and is still the only organization that does, is oversees care provided across the entire community. It sets standards and sets programs to help providers improve the care that they provide across the entire spectrum of cancer care across the whole community. I think that's been the strongest contribution of the Commission on Cancer. I think it continues to be the strongest base for it. So far, about 75% of all cancer patients in America are treated at a Commission on Cancer accredited program. It would be great if we could make that 80% or 90% or even 100%. But we've got a lot to be proud for. The National Cancer Database is another one of the really strong programs that they've promoted. Again, David Winchester and others got the American Cancer Society to join on board to support the development of the National Cancer Database back when when cancer registries were finally being computerized in the 1980s. And that matured under Andrew Stewart's leadership and now under Ryan McCabe's leadership into one of the most important cancer registries in the world. It's not truly population-based, and it's always a little bit of a limitation, but with 70% of cancer patients, it's coming pretty darn close. Is widely used. Actually, it was during my term that we came to agreement with the American Cancer Society and came to a mechanism to make those data widely available to the research community under what we now call the participant user files. And that was, I think, 2011 or 2012. Hundreds and hundreds of landmark papers that have really helped change the landscape of American oncology and oncology worldwide.
Thank you very much. Dr. Edge, tell me where you think the commission ought to be going in this current century.
I think the commission is moving in the right direction to enhance its data standards, to establish mechanisms to collect data and use that data in a real-time, structured way, relying less on hand abstraction and more on electronic data capture and artificial intelligence. I think that Dr. Nelson is moving us in those directions. It's a long road and it's a very expensive road. It will require additional partners, but I think the college is uniquely situated to work with the providers across the United States and to work with the large informatics researchers and informatics companies to establish really meaningful tools to help patients and doctors assess and improve the quality of care.
I think one of the next questions I have is, how do we make the NCDB work better? You alluded to it a little bit, but please educate me as to how we're going to get there from where we are now. I think you fully understand the pros of the NCDB. You also understand better than most the downsides of the NCDB. So how do we make it better?
You know, the NCDB is a unique resource because it covers such a large fraction of the American population, and it's available for researchers around the world. We need to enhance the structured documentation in our records and the accession of structured documentation, both from our medical records and from our administrative data into population registries like the NCDB. We cannot continue to rely solely on hand abstraction to collect these data. It may require new informatics tools. It will be that this effort will be sped along through efforts to promote interoperability and transparency of data. I think the NCDB is probably going to, I hadn't thought about this until now, so I'm talking a little bit off the cuff here, but we may need to look at another dimension, and that is make more data available to patients. Transparency is really important in medicine. The Cures Act is certainly promoting that in our own medical centers, but finding ways where we can collect data from patients with patient-reported information and provide data to patients. using tools that can be developed from the NCDB to help them understand toxicities, to help them understand treatments that are available to them, to be included in decision support tools. These are very difficult things to do. It require partners in industry, partners in academia, but I think the NCD is situated in such a central location in the hub and spoke system of informatics and oncology that we have the capability to do that. And of course, we're not a for-profit company that's looking to profit from these data. The only profit we want from the data are improved care for our patients.
The last question, Dr. Edge. You've spent your entire life working to improve the quality of cancer care. One of the struggles as somebody who spends a lot of time doing that in a large system as well is the definition of what quality is, because as you know, we have a lot of, and I think the terminology the CoC uses is excellent. We have a lot of surveillance information, but truly nailing down what is a quality metric. I know you, the phrase that popped into my head is you fought the quality wars over the years to try and determine what is a quality metric. We have huge discussions about just what would be seemingly straightforward things like 12 nodes and a colectomy.
Mm-hmm.
Educate me as to how do we determine what a quality metric is and the process by which we should vet those and push them out to the community.
Well, historically, we've developed quality metrics by looking at processes or potentially outcomes. We do focus more on process measures, partly because getting outcomes is hard. Survival is, of course, the outcome we really want, but it's not really terribly sensitive to quality because there's so many other factors, biologic, patient factors, and others that play into that. And survival takes so long to determine for many cancer types. Thankfully, it's even longer now for some that were very short, such as lung cancer. So quality may not, survival may not be a useful quality measure to help you at the Levine Cancer Center improve your care because you'll be looking at survivals from 5 and 10 years ago. So we want to find things, processes, and other factors about care that will impact on outcome, preferably to a fairly large number of people, and make sense both to the patient and make sense to the provider and to the institution. So that's largely how we select quality measures. Specifying the quality measures leads to a lot of discussion, of course. Though I personally think we should be looking more to decision support than we are looking to static quality measures. That we should be looking to tools that help us take the information we have on an individual, synthesize that, and define the best treatments and the best approaches for the individual. And that may be, I mean, right now, many of us are using what we call pathways, where we have basically guidelines, and we know that for a node positive colon cancer with certain characteristics, that they should or should not receive specific chemotherapies, or they should or not receive specific operations, or the timing of the therapy should be before or after surgery. But I think the future is going to see where we're going to be able to more individualize that, certainly with genomics, and we'll see more individualized care. And I think that we will be moving in the direction in quality measurement, actually real-time decision support, so that when you're seeing a patient, when a patient is searching you out and is looking at the information themselves, there are tools to help them really define what is their best option.
Well, Steve, thank you so much for taking this time.